Okay, so this is going to be a video on an advanced perturbation and neuromuscular progression. So we know there are key elements that make for an effective postural control and neuromuscular intervention. And there's 6 here that are laid out that I think are some of the most prominent and some of the most effective, demonstrating better outcomes. The first is optimal prescription. We need to ensure that the intervention has the adequate frequency, volume, and intensity appropriate to make physiological changes within the central nervous system and the neuromuscular system. This also entails feasibility and sustainability of the actual means by which a person can take part in the intervention. So this means usually low-tech equipment that can be transferable from one clinical practice setting or one home setting or one gym setting to the next. Additionally, we know it needs to be individually challenging for the individual. We also know that it needs to be variable. Variable practice within motor learning enhances the motor learning task at hand, allows for better transferability to novel tasks as well, and both of these need to be respected when providing an intervention. So it also likely needs to be adaptable over time, that variation is occurring and that progressive challenging tasks are applied. Comprehensive types of postural control, so this is static as well as dynamic tasks. Additionally, there needs to be anticipatory as well as a reactive element to their neuromuscular interventions. There's this unique concept that's coming more readily to hand and more evidence is mounting called sensory reweighting. In short, the explanation or definition of a sensory reweighting is where the brain develops a new task or puts more emphasis on a particular afferent or sensory input to be able to accomplish a motor task. So the example here is really within the lower extremity. In a healthy individual, they're going to be utilizing a sensory motor strategy. In layman's terms, that means they're using the sensory information that's coming up from the limb subconsciously to be able to then react to that sensory input from a motor aspect to create the appropriate motor strategy that is otherwise necessary. And because this is occurring on the subconscious and really on a less cognitively demanding level than is the opposing, and we'll get into that, then it allows the individual to better attend to the environment at hand and to be able to have a more robust strategy to prevent subsequent injury. On the other hand, what we see in injured individuals is this sensory reweighting where they rely more not only on a visual motor dominance, but they also develop a higher cognitive load for a given motor task. The negating effects of this are that the individual's cognitive bandwidth and visual bandwidth are taken up attuning to their internal processing rather than on the external environment, delaying reaction time, mitigating their decision making, as well as their speed and their overall physical performance. And so we need to be sensitive when we're implementing different interventions and training strategies that, one, we're respecting the sensory reweighting and not reinforcing it by any means, but hopefully we're coming up with novel interventions and progressions that would counteract this visual motor or this additional cognitive load that an individual experiences following lower extremity injury. And as we go through the progression explained within this video, I'll describe how I think that this progression actually gets directly at that, or allows for interventions and strategies to counteract the sensory reweighting. And then we also need to ensure that the intervention at hand is adaptable to the individual and that it applies directly or as close as we can to the motor task, the activity, the sport that they're trying to get back to. Within this described progression, are 5 levels. So you have level 1, initiation, level 2, intensity and distance, level 3, rate of stability progression, level 4, sport-specific task progression, and level 5, rate and sport-specific task progression. In the second column, you have the different techniques applied, and then the distance and the cord resistance. And these terms and these variables will make sense as we go through the progression in detail. So the different techniques, again, it's going to be a step and hold for levels 1 and 2 with a progressive distance in from level 1 to 2. And you can see the italicized and bolded text in the table denoting the variable that is being progressed from one level to the next. So from levels 2 to 3, you have 3 repeated step and holds requiring a more rapid rate of stability, hence the title of level 3. Level 4 is a step and hold, yet you're now incorporating ball tossing, dribbling, individual adjusted relevant sport or task specific activities. The core tension and the distance relatively stay the same. And then level 5 is a combination of level 3 and level 4 where you're incorporating both a rate as well as a sport specific task progression. So in level 5, you can see that you reintroduce the 3 repeated step and holds that were seen in level 3, and that's then combined with the sport specific and or activity specific tasks that are incorporated. You can see the asterisk symbol denoted in the annotation below the table that states performing exercises on unstable surfaces or without visual or cognitive distraction is suspected to reinforce that visual motor sensory reweighting that we talked about that is disadvantageous and can lead to subsequent injury, particularly when the individual goes back to their open and uncontrolled environments. Thus, whenever possible, interventions in exercise should be performed with eyes closed and visual perturbation, that is to say, rapid blinking or stroboscopic glasses, or sport-specific skills and neurocognitive tasks should also be incorporated. And one of the more common examples of this is using augmented or even virtual reality headsets in combination with such interventions to allow for the disturbance between what is actual false sensory information, forcing the brain to then attune to the sensory motor input and that more native strategy. Additionally, you can see the cross here in regards to the cord tension. So each intervention and each level should be appropriate for the just manageable challenges or just achievement of the task at hand. And this is going to be patient specific, and this can even dynamically change over the progression as the individual accommodates to the new variables that are being added, as well as it enhances their performance with their neuromuscular stabilization. Traditionally, the cord resistance is applied with a sport cord or TheraBand, but any accommodating resistance will otherwise suffice. Again, this gets to the feasibility and the applicability of the intervention across different practice settings or training settings. And then I've included a couple of sources there that were influential in helping me design these different levels. Okay, so you have in the first column different training variations. In the second column, you have the emphasized plane of that different variation. And then you have the actual broken down delineated tasks or exercises at hand for each of the different variations. Now, is convention within rehabilitation and training that help an individual to own what is the sagittal plane, that means forward and backwards, and then the frontal plane, that is to side, before you get to rotational and or combined planes of motion. And so the variations follow that same methodology. And so you can gradually introduce the different variations over time to someone's training program if they're not otherwise ready for the combined and or rotational planes. And then also keeping in mind that typically this is going to be prescribed 2 to 3 times per week, as is the most effective dosage when it comes to neuromuscular progressions and stabilization, postural control training. And so what this allows for is a cycling of these different training variations from one bout to the next. So on a given training bout, the individual would only perform one variation. And then this allows the exposure of the different planes of motion across a training regimen without actually having a superfluous or an infeasible amount of different variability within their given training task. For instance, if we were going to try and train all planes within a given training bout multiple times a week in combination with other stimuli and training that the individual needs to do, it likely would not be feasible nor sustainable. And so that's the key when it comes to periodization and programming appropriately. And additionally, this allows for structure, yet also variability within that structure, which we know that variability component is important for motor learning and task transfer. Okay, so then we're going to go through what do these actually look like. So here's an example of the sagittal plane. So you have an anterior step and hold away from the cord with the back of the patient. A lot of evidence that has shown that using systematic reviews and more pooling of the literature that there's actually about 6 to 10 repetitions or 60 seconds per set if you wanted to do it timed. You didn't want to have the athlete actually counting the repetitions, then that's another option. A minimum of 2 sets, and then the frequency has been described as anywhere from 1 to 3 times per week, depending on the training status and the load-bearing capacity that the athlete can actually take, and also considering where they are in their training season or in their phase of rehabilitation, what is otherwise being emphasized at that time. And keeping in mind here with the symbols, though these are kind of the minimal effective dose, the volume of the program is individualized to each patient based on the treating therapist or trainer, and based upon the patient's tissue response, training experience, and cumulative load across the different phases of rehabilitation, or if they're a healthy athlete and return to more team-based training, then that would also suffice. Okay, so just quickly revisiting the key elements of postural control and neuromuscular interventions that we described. Optimal prescription and volume based off the literature. We need it to be challenging and variable. We have that. Comprehensive types of postural control. We have static as well as dynamic. We've incorporated anticipatory as well as reactive. We've accommodated to the sensory reweighting and trying to adjust that, adjust for that principle so that we're not only avoiding the reinforcement of the visual motor strategy, which would come with just sticking someone on a BOSU or unstable surface, but rather we're allowing for novelty and creativity on behalf of the therapist with strategic strategies or suggestions that have actually shown to promote more of the sensory motor dominance in the reacquisition there within of the central nervous system, rather than the continued reliance on the higher cognitive load as well as the visual motor strategy that usually transpires. And again, you can make these very task and patient specific. So here are a couple of references that have influenced the creation of this progression. I hope that you find it helpful. Please leave your comments in the section below. Always looking to get better, always looking for constructive feedback. And I know that when we put our heads together, we're better together than we are apart. So thanks for listening.